Gonna record first. And now I can admit.
Okay. Again, just let me know when
Yeah, let's give it a little extra
So-
second because I had a couple people just pop in, so it might take them a little extra to get on.
yeah, just give me
I have
a signal.
558.
Yeah,
I still have people coming in the waiting room, so. And Stevie, if you want to go ahead and put your slides up, you're more than welcome. And I have everybody in, so.
okay. It's 6 o'clock. All right, we'll get started. Okay, we're going to get started now. So I'm Dr. Shawn Baca, past president of County Medical Association, and today we have the discussion about drug pricing and transparency, and we're going to have two speakers, myself and Dr. Stevi Jenkins. So Stevi Jenkins is a PhD pharmacist. She has lots of experience. She's worked both on the retail side and the private side, and is actually working on opening up a private pharmacy. And so we asked her to come to discuss issues with drug pricing and transparency from a pharmacist's point of view. Patients were all frustrated with these high prices, and pharmacists and doctors are too, believe me. You know, most of this is structural stuff created by insurance companies and a lot of bureaucracy. And so she's gonna give us a talk about what it looks like from her perspective as a pharmacist. So take it away.
Thank you, Dr. Baca. Good evening, and thank you to the Medical Society for inviting me to speak about drug pricing and transparency. This is such an important topic because our patients' access to medication and their ability to afford their care is essential to really reaching their health outcomes. Before we get started, let's just cover my conflicts of interest. I currently do work for a grocery chain in Palm Beach County. I serve as an alumni association member for the Gregory School of Pharmacy, and I am the owner of the My Concierge Pharmacy based in Palm Beach County. Putting all of that aside, let's talk about what to focus on first when it comes to managing the prescription drug pricing. And believe it or not, it's really your pharmacy benefit selection. You have to start at the beginning. It's that time of year, the time for pharmacy benefit selection, and this is normally combined with the patient's medical insurance. If you have patients who have been having a difficult time with drugs that haven't been covered, prior authorizations or high copays, this is where they really need to focus their attention before the beginning of the year. So does the patient's place of employment offer insurance? This plan is usually the least flexible option because most employers do not give options for which plan a patient can select. If there are options amongst the patient's place of work, then I would recommend for them to directly contact the plan with their current medication list. to assess the average cost per year. And this will really help them to have the most cost-effective option. Something that a lot of people don't think about is really looking at their patient, that their spouse's insurance. They don't look at it, they think that the premiums may be higher, or perhaps that they would have to pay a health insurance surcharge for using their spouse's coverage. However, in my personal experience, it was actually the most cost-effective option. So it's worth looking at. When you start running primary and secondary insurances with their plans, it can become extremely tedious. So selecting that original plan that you want your family to use, again, in my own experience, is much easier than having to manage multiple plans for a family. This reduces insurance claim requirements, the coordination of benefits, and it really just streamlines the access to your health information by only having to go through one portal. Many patients who work part-time, they may not be eligible for health benefits or may be self-employed. These individuals should usually check out the healthcare.gov website for their saving options on health plans. They have very affordable options, and they do have a wide range of prescription coverages that are available within each of those plans. And of course, last but not least, we have our patients that are over the age of 65. The open enrollment has already begun. And if you have these patients that have been having a difficult time with coverage for their injectables, stroke, DVT prevention medications, now it's definitely the time for them to switch plans. And I know it can be daunting, but the easiest way is really for them to call in and speak directly to a representative. The websites are not as user-friendly for our patients that are over 65. So them being able to speak to someone directly usually helps them to choose the best plan option for them.
I just want to remind everybody this program is being recorded.
So now what? The patient needs to know how much they are able to spend on their medical costs and prescriptions comfortably. But what do we think of when we're really selecting that coverage? Or what can we talk about with our patients when they're asking us questions about different plans? So what are they willing to spend in an emergency? What are they willing to spend on their maintenance medication? So we have deductibles. We're in the day and age of high deductible plans. And if these plans are selected, the patients will mostly out of pocket their prescription costs for the entire year. A lot of the plans offered by employers are high deductible plans. And this is in order for them to be able to utilize an HSA card. We see a lot of patients that are unaware that the prescription costs are tied into their plan's deductible. And the plan may state that they have a $40 copay for that tier 3 preferred brand. However, the patient may never go past their deductible unless there's a catastrophic situation that actually happens. So they don't actually get to enjoy that $40 deductible or that $40 copay. We have percentage shares that are coming up in the market. And these are plans that are becoming more and more prevalent. And they provide their employees with a prescription card, but it's not essentially insurance. It's more of a discount card offering. The issue with this is that the price the pharmacy will charge is given a percentage off to the patients. So the patients end up spending much higher costs than they would with really a standard discount card. So it's not much of a benefit to the patient. Now within the plan, most patients are aware that there's tiers. But what are the tiers of the plans? What medications aren't covered by these tiers? The biggest complaints that we have usually come from the cosmetic realm of medication. That's that anything that's for aesthetic purposes, whether it's acne, scar tissue, or numbing agents, those are rarely, if ever, covered by prescription plans and can become costly for some of our patients. The copays within the tiers. When you're looking at the plan, a plan may seem very enticing because it has a $10 generic. However, all brands require a prior authorization. Patients consistently pick these plans because they think, oh, well, I'm completely fine with taking generics. I'll never need a brand. However, one hospitalization later and the brand medication is a life-saving option that they have to have. And this becomes extremely cost cumbersome for them. Do we have preferred pharmacies that the patient has to use when they select a plan? Do you have to go to CVS? Do you have to go to Walgreens? Do they have to use mail order pharmacy to utilize the benefits within their plan? Do they have to get 90-day prescriptions? So understanding what their limitations are within that plan and what pharmacies they can use within it. At the end of the day, they need to understand what is their total out-of-pocket expected cost. In the plan comparison tools, they'll usually show the premium projected cost and the out-of-pocket cost side by side so that the patients can review that. So we picked a plan and we've compared the cost and we're really ready to use it. But where do we go to answer these questions and who do we speak to? So let's go over. So if we have an insurance question, it seems obvious, but you should call your insurance company. Other than the very small percentage of physicians who have a collaborative practice with a pharmacist, all patients should be referred to the insurance help desk for their plan-specific information because there's such variability. It's not like it was 15, 20 years ago where everybody knew what each plan was included. Can calling the insurance be an arduous process? Yes, but it's really not always. And the patient speaking directly to a help desk representative can easily answer questions for the patient, which they may have avoided calling into the insurance company for quite some time. The online websites that are available now, they're an excellent source of information, and they have most of the forms and details about the patient's plan if they're computer friendly. This can usually be accessed either through the work provider or directly through the plan website with their login information. There's also phone applications. Each plan has an application. They have an app for that, and they've got one for this too. These applications are where a patient can see a broad overview of their plan usage, claims, explanation of benefits. And there's also educational tools for disease state management and overall health. The pharmacy, are they asking questions to the pharmacy? The patient can request an explanation of costs directly from the pharmacy for an individual claim. The pharmacy personnel can usually quickly tell whether a medication is approximately in the right range. And if a medication is obviously a high cost, pharmacists can give alternative ideas for the patients to use. Pharmacy applications allow the patient to see their copays before even visiting the pharmacy. The applications also allow patients to refill their medications and to receive adherence reminders. The patients can call their employer. Having a problem with their plan or their price, they should try to speak to the human resource benefit representative, especially if they're part of a larger company. They may be able to make a plan adjustment upon their re-enrollment with a plan for its employees. I just wanted to go over how I go about looking for information using these tools that I referenced. So using applications, using pharmacy equipment. So I pull up my medical apps. I see that I have different types of claims that are available. And I wanted to look into which medication I paid $6.56 for. I just couldn't remember what it was. And I saw it on my bank statement. So I find the claim, I find how much it was. I pull up my pharmacy app and I'm able to look and see what the prescription number was, what the medication was, what it was for, how I took it, and even the doctor's phone number is provided. So just taking those steps to use what resources I have available to be able to really evaluate the cost that I'm paying and what I'm paying for. So understanding prescription pricing. Why the wide range of pricing? Well, we know brand versus generic, right? Brand medication is always going to be more expensive than generic. But generic does not mean it's cheap, especially if something just went generic. So keeping that in mind, if you have a product that just became a generic, it might not be accepted yet by the insurance company as a preferred product. Compounding versus retail. Compounding is a time-intensive process, and however, we shouldn't assume that it's more expensive than commercially prepared products. One of the most common products that's cheaper in compounding is actually hormone replacement products. In the pharmacy, they're very expensive, but in a compounding pharmacy, because that's something that they prepare on a consistent basis, that would be the preferred and cheapest option for a patient to go to. What about the day supply? Most doctors and patients alike are so used to the 30-day and 90-day supplies, but this came about due to insurance restrictions. When I first started in pharmacy, we commonly would fill 6-month to year-long prescriptions for patients, and that was more the standard. So we got used to doing these 30 days. We've gotten used to doing 90 days. But if it's cheaper for a patient to utilize higher day supply, we should use those options, especially if they don't even have to use their insurance for it. What about tablet versus capsule? An example that I brought up is Furacet is extremely affordable in a tablet form. However, it's 4 times the cost in just a capsule. And this is a commercially prepared product. So if you had a patient, wouldn't they prefer to pay $10 versus $40 for a common product? We also have other things such as special formulations. When we get into inhalations, nasal sprays, creams, refrigerated products, etc., they're always going to be more expensive. Within those special formulations, though, by speaking to the pharmacist, we can tell you which ones are the most commonly used, and those will be the cheaper options for the patients. Compound ingredients versus single ingredient products. We love the products that have multiple ingredients, especially to improve adherence in our patients. But a lot of times the single ingredient products are far cheaper than the compound ingredient ones. Why the cost difference between the pharmacies? Well, we do have the insurances. So let's start with the tiers. Each pharmacy has a preset price or a percentage share of the cost, and is a percentage share of the cost that's written into the system. So each pharmacy is going to potentially have a different cost, even though there's different tiers. So it might be $5 at CVS, but maybe at Publix, it's $10 through your tiers and preferred pharmacies with your plan. Then we get into preferred pharmacies. So a great example is Aetna, CVS Caremark. Would it be surprising that Aetna offers lower costs for their patients if they get their meds through CVS Caremark? That would make sense because you would want to make the most money from your own pharmacies. We also have manufacturers. So 2 pharmacies may sell lisinopril, but the pharmacy that has the cheapest contract for purchasing lisinopril will have the best opportunity to have the lowest cost lisinopril for its patient. So just because it's the same product does not mean that it's the same cost. We have a wide range of manufacturers. For most products, I have a minimum of 5 different manufacturers that we have an opportunity to purchase from. And so there is a huge variance between prices. What about the buying power of the pharmacy? Looking at something like CVS versus Winn-Dixie, CVS has approximately 10,000 stores almost, whereas Winn-Dixie has approximately 225 stores. So a company like CVS is going to have massive buying power in comparison to a company such as Winn-Dixie. And sometimes that's indicative of their pricing, and other times, as we'll see, it's not. What about coupon contract and pricing? Like, why can't you take your coupons to any pharmacy? Those are actually contracted. You will see coupons that are only available through Walgreens. Maybe they're only available through Publix, and that's because that pharmacy contracted for that price. So it's only going to work at that pharmacy, and the pharmacy has to be willing to accept the coupon. So that's kind of more on the administration end, but all coupons do not work at all pharmacies. So this is through GoodRx. I wanted to do a comparison so you could see this is not through insurance. We are only using a discount card, and we're just kind of look at where could you go to get decent prices. So I have 3 pharmacies I've never worked at before: Winn-Dixie, Walgreens, and a random local independent. And I ran these different prices through it. So atorvastatin is probably my biggest seller. We sell tons of atorvastatin. It's very common. But if you wanted to get 30-day supply of atorvastatin, where might you go? Well, based upon this, Winn-Dixie is actually going to be the cheapest option. They're also going to be the cheapest option for atorvastatin if you want to get a large supply, such as 270 days. And what's interesting is if you look at the Walgreens column, for the same amount of product for 30-day supply, Walgreens, though they have approximately, I believe, 9,700 stores, they're 3 times as expensive as Winn-Dixie, who has 225 stores. So it's not necessarily going to be cheaper depending on you're going to a pharmacy that's a retail company. It really depends on their marketing and also their ethical pricing of the medication. If we look at something like omeprazole we sell tons of, and it's available over the counter. So it's even funnier to me that they will price gouge in certain things like this. For example, if you look at the independent pharmacy, for a 3-month supply, the independent pharmacy who owns 1 store is charging $18.58, whereas the Walgreens, who has the largest company, is charging almost $30. So really looking at the different prices and understanding that you're not necessarily going to pay more at a local independent or a Winn-Dixie or a Walgreens, but it is worthwhile to check your prices if the cost is a large factor for you, or if the cost of your medication keeps increasing. So what's the holdup? Whenever we receive the prescriptions, why aren't we filling them? Why are your prescriptions not ready when you come in to pick it up? It should be easy, right? You send it over to us and we should fill it right away. Well, just like sometimes there's holdup in a doctor's office, there's holdups in a pharmacy. The number one reason being it's not covered. It's requiring a prior authorization, or it's a very high dollar item. We usually will not fill prescriptions that are over $100 until we speak directly to the patient, because we don't want to order something the patient's not going to pick up. So we're waiting to hear from them. The second most common issue is inventory. We don't carry everything, and we don't always carry a 3-month supply of every medication. It doesn't take long for us to get products in. It's a 1 to 3 day turnaround at most pharmacies. But something being out of stock is a common issue that patients run into, where they'll come in to pick up their prescriptions and we don't have it ready because we're still waiting for the order. Number 3 would be an incomplete prescription. This means it's missing information, or it was incorrectly written, or maybe there's just something we have to clarify. Maybe it was ineligible, like we just couldn't figure out precisely what they were getting at that they needed for the patient. And then number 4, which is probably one of the biggest one that's as difficult on our side, is refill authorizations, where we've contacted physicians' offices. We're waiting to receive a receipt of either an authorization or a denial. And so we have patients all day that will come in looking for their prescriptions, and the refills are just not authorized, and that's why they're unable to pick them up. So how do we get around some of these problems? We have cost problems, we have insurance problems, and we just have prescriptions not ready whenever the patients are coming in. And the easiest way is really know your pharmacist. APHA ran an amazing campaign. I was on an international level, and it was so important because knowing your pharmacist really helps your outcomes, drug costs, and it's linked to better patient relationships. So the average retail pharmacist is filling 300 to 600 prescriptions a day. They estimate that a pharmacist cares for approximately 2,000 to 3,000 patients a month. And out of those patients, the pharmacists only know about 10% of their patients' name. So if we're wanting a pharmacist to run a manufacturer coupon, make a recommendation, then we're going to need to know that person to be able to talk to them and show them that we need their assistance. Pharmacists on average will spend less than 2 minutes total per prescription. And I think I was giving a little bit more time on that than it really actually is. But it takes us about 5 to 10 minutes to apply a manufacturer coupon. So you can see the difference where if we're used to spending 2 minutes on a script and now we're being asked to spend 5 times as much time, we're going to need to have a little bit of a relationship, a conversation to be able to help people. And in the health industry, we've seen a huge increase in our workload. So with COVID-19, the pharmacists have been providing anywhere between 20 to 85 vaccines a shift. And these are accurate numbers. And I would say 20 vaccines a shift is so low. Most pharmacists are doing at least 40 a day during flu and COVID vaccination seasons. But I think we kind of underestimate how much the technicians can do for patients. We don't really speak about the technician-patient relationship, because an offer to counsel is given to all customers by the technician, and only the patients who request the counseling are actually provided it. But these patients can ask any questions that they want. They can ask about prices, their interactions, alternatives. They can ask insurance questions. They can ask me anything that they want, but they do need to ask for me to come over. But the technicians have more time to really assess cost savings opportunities and to discuss it with the patients. They're even more efficient at insurance adjudications. And I'm sure in the doctor's office, I'm sure you have a nurse that is better at doing something than you are. You have to, like, they're the ones doing it. They're faster at it and they're quicker. They have experience with the copays. They have experience with manufacturer coupons. So I would urge that the patients and the doctors utilize the technicians to the best of their ability. That's what they're there for. So what are our ethical considerations with this? It gets a little sticky. We have a lot of workplace responsibilities. Pharmacists are in lots of different locations. We work in independent pharmacies and we work in corporations, but we work more in corporations than we do in independents. We can work in hospitals and we can work in specialty pharmacies. We can work on site or even in collaborative agreements. But no matter which location we're working in, we are going to have certain goals, whether it be vaccine goals. I've never had a year where my vaccine goals have actually decreased. They've only ever increased for our patients. We have workflow protocols. Some of the largest corporations will have very strict rules and procedures of how we are to interact with patients, who's to pick up the phone, who's to call the doctor, and we are expected to follow those workflow protocols whenever we are at work, obviously to maintain a job. We have time considerations. So the pharmacists, although they may want to help as many patients as possible, they also have to help all the patients that they're filling their prescriptions for. So they're kind of weighing that back and forth, like how much time that they can give to one while still maintaining their duties and at their job. They have net profit. Our pharmacies are designed around it. They look at net profit. When on a corporate standpoint, that is one of the first things that they will look at is how well the pharmacy is operating. And we do have the pharmacy benefit managers, like where they will come back to us and they will take the money back from us. So when we submit a claim for a prescription, if we submit a prescription for, say, $10, because that's what we are needing to earn on a medication, but our contracts are only actually set for $7, we will lose money in that deal. And so some pharmacists, although they want to process everything through the pharmacy benefit managers, they may actually see an opportunity where they can actually make more money with processing it through discount cards. So a lot of people think that pharmacies lose money by using discount cards, but the truth of the matter is they don't. They don't lose money because we're here to help patients and to fill prescriptions, and that's how we actually make money. In 2018, through Congress, there was a Patients' Right to Know Drug Prices Act that passed. Most people don't realize that before that, the pharmacists were really not permitted to discuss cheaper alternatives to patients. It's not that they didn't, but they technically weren't permitted to, because they would have had blowback from the insurance companies. So now are pharmacists able to recommend cheaper alternatives? Yes, now they are. However, it doesn't mean that they might not still have corporate initiatives that they still have to follow. Are pharmacists required to maintain the sales of pharmacies? Yes, whether they own the pharmacy or they work at the pharmacy, we are 100% responsible for maintaining all sales of the pharmacy, which is a huge conflict of interest, because if we're trying to save people money, then how are we able to maintain the sale of the pharmacy? And what is an average pharmacist compensation really correlated with? It's really correlated with sales, service, and expenses control. The expenses control it varies, but each corporation will give a pharmacist certain key performance measures or key performance indicators of what they expect from a pharmacist, such as vaccine goals and net profit. Let's do an example. The patients a patient wants to take brand only Cymbalta 60 milligrams, but they have always taken brand and they do not want to switch. This medication is not covered by their insurance despite a lengthy prior authorization process. So what are their options? Well, the cheapest available at this time is $774 for a 90-day supply at an independent pharmacy. So they're going to be looking to spend approximately $258 a month. They can use their HSA spending account to cover the cost. They can also call their employee benefit representative for an exception. They can use an alternative generic. It's $7.07 for a 90-day supply at a retail chain. And this is $2.37 a month. I think the most important thing to understand is that patients do have options. It's just being able to look at all of their options and to be able to make an educated decision, and to know that those options can actually change in the future, with being able to reevaluate what insurance they have, being able to use generic or products that are more cost effective, and by really developing a relationship with their pharmacy. So thank you so much, Dr. Baca, for having me today, and I'm going to hand it back over to you.
Thank you. Okay, so what we're going to do is we're going to get started. So can we see these slides?
No,
Mindy?
I can't see your slides.
Okay. Hold on. Share.
Thank you, Stevie.
There we go. Okay, so.
Now we can see them.
Okay, so what we're going to talk about from my perspective as a physician is that patients come in all the time and they're concerned about how can they reduce their drug costs, because they're pretty high and they're very untenable. But what I found as a physician is that there are a million different ways that we can work around it. And so you have to, first of all, just start with the premise that if you think you're paying too much, you probably are. The healthcare drug delivery system is complicated and I would say dysfunctional. And then Americans pay 3 times as much for the same medications as citizens of other countries. Now, so what's wrong with drug pricing? Well, we know that basically insurance companies and PBMs, the pharmacy benefit managers, set the prices. And what the PBMs do is they demand rebates from manufacturers. And it's not really an optional thing. It's really a kickback. And if you don't do it, you can't get your drug in the formulary. And some of the rebates on some of the name brands can be as much as 80% of the cost of the drug. So of course, this causes drug inflation, raises drug costs and premiums. So the Federal Trade Commission years back said that rebates are not considered kickbacks, but Enron did the same exact thing with electricity, and that was considered illegal. But a drug company, not the drug companies, but the insurance companies and the PBMs are doing it right now, and they are not considered kickbacks as of now. But The FTC is investigating it, and the game may change. So essentially what it is a shell game. What happens is the PBM comes in. Now, what people don't understand is the PBM is owned by the insurance company. So PBM is insurance. So essentially what happens, the government set a cap for insurance premiums not to go above 18%. So they purposely pay too much for the medication. They move it over to this bucket, which is a PBM, which they own, and then they take the profit off as a rebate on this side. And then basically they're able to keep your premiums nice and high. And then they basically can pretend that they're spending a lot of money. And then basically they're able to extract a lot of profit of the system. You know, if you look at the Fortune 10 companies, 10 out of the 3 of the 10 are actually PBMs, which is pretty amazing that they don't manufacture anything, they don't warehouse anything, they don't ship anything, and they're actually making more money than some of the pharmaceutical industry. And this is somewhere around $300 billion this year, which is basically a third of $1 trillion is going just to the PBMs for rebates. And this is a way to lower drug costs and help people be able to get better health and reduce insurance. So this really needs to be looked at by our elected officials. So in terms of generic medications, they're generally cheap, right? Wrong, because you just saw examples from Jenkins that sometimes insurance companies actually set different prices, and they often use what are called spread prices, where they'll charge more for a drug than actually what the drug can be obtained at a cash price. So what they do is they keep the difference. So sometimes your insurance company actually makes a profit off of you when you buy a drug. They actually pay less than what you pay for it, and they take it back home. And that's just not acceptable, since insurance is supposed to lower your cost by pooling risk. So they actually make profit off of you everywhere down the chain. So it's just really not a good idea. But remember, you're not obligated to accept the price your insurance company gives you. So, you know, like the song says, you better shop around. So let's start saving some money. So basically, there's a different strategy for each type of insurance, each type of pharmacy. So we kind of went through that a little bit recently. And make sure that you understand that you're not limited only to one choice. And you don't have to use your insurance sometimes. Sometimes you're just better off just going on your own. So the first thing to do is talk to your doctor and see if there are alternative medications. Perhaps a medication that's generic might accomplish the same goals as the one they prescribe. Sometimes it can help, sometimes it can't. Now, if you have over-the-counter medications, generic, name brand, infusibles, injectables, each one has a different strategy. And basically, with injectable medications, you want to know if the medication can be given in the doctor's office, at home, or both, because that can make a huge difference. Let's see. There we go. So in terms of prescription size and strength, we went over that recently. Basically, ask for bigger supplies, even perhaps a 365-day supply may be less expensive. The other little trick that sometimes is that not all medications, you can't do this with capsules, sometimes they're flat priced. So they may charge as much as a 40 milligram pill as they do for a 80 milligram pill. So sometimes you just buy strength for X number of pills, and you can reduce your cost. So, you know, again, you got to talk to your doctor. You got to let them know what your situation is. And if you're unhappy with what's going on, they probably can work with you and figure out ways around this. Now, in terms of pharmacies, we just went over that in detail. And basically, each pharmacy has a different price for each medication. And this is especially true for generic medications, as you saw that last table. Generally, the large corporate pharmacies usually have the highest prices, even though they potentially have the biggest buying power. They also seem to take advantage the most. So typically, you're better off with a discount pharmacy, an online pharmacy, or local owned pharmacy. They generally have the better prices, and generally you get better service from the pharmacists. So in terms of generic medications, cash can sometimes be cheaper. You want to check your insurance price versus your cash price. And the way you do that is you start with an online discount coupon site and an online pharmacy. So these are some of the coupons. Now, these are all in the Palm Beach County Medical Society website, so you can find the references to this. But we have GoodRx, WellRx, and RX Saver. And basically what you do is you open up that. It's without cost. It's totally anonymous. You put in the name of the drug, the price, etc. It'll give you a coupon. And so that should be the coupon. And it'll tell you which pharmacy has each price for each coupon. And so you can basically test your cost versus what the insurance is going to charge you. And if you think it's too much, then you basically want to use the coupon price and you present to the pharmacy and say, I want to use a coupon. I don't want to go my insurance. And then you go from there. Now, online pharmacies are also available. Mark Cuban, you all know, he just opened Cost Plus Drugs and basically charges only a small percentage above what it costs him to buy the drug plus shipping. And some of their prices are very good compared to some of the ones that you can get at local pharmacies. Also PillPack from Amazon, Blink Health. So there's some other ones as well. All you have to do is just register. You basically put in your credit card, and you can sometimes get some of the generic medications this way. These are not going to work for name brand medications. In terms of insurance types, basically, again, you've got government operated and controlled, government subsidized, and commercial plans. So government operated ones are like the Veterans and the Indian Health Service. And they have the most restrictive formularies, a little harder to basically use, but at the same time, they're also the ones that typically are the least expensive. So if they do approve a drug, you're going to be able to get it for much less money than not. But you're going to have to belong to the group. For example, you got to be a veteran, or you got to be First Nations people in order to qualify. But again, if you do, you have to go see their doctors for specific things. Say, I need this prescription, and generally they'll fill it, provided that that it's on the formulary. But again, it may not be. But this is sometimes a way to get certain prescriptions for much less if you belong to these groups. Now, government sponsored would be like Medicaid and Medicare. In Florida, in most states, Medicaid basically is now in an HMO system, and basically that's controlled by private insurers and not by the state. And basically they have very restrictive formularies. Out-of-pocket expenses, however, are also very, very low, but that's only if the insurance agrees to cover it. A lot more paperwork, but these are generally not so bad in terms of copays if they'll cover your drug. Of course, they basically in Florida are run by HMOs, and so therefore, again, you may or may not be able to get your prescription, but if you do get it, you're generally not going to be burdened with high copays. Now, government-sponsored Medicare, you essentially have traditional Medicare and managed Medicare. And basically, I'm cautioning everybody here, you got to choose carefully, because basically, if you choose a less expensive managed care plan, or what they call Medicare Advantage, or we call them disadvantaged plans, basically they're more restrictive, they have higher copays. Sometimes, if you leave the plan or you're unhappy with the plan, sometimes it's hard to get out of them, because what Medicare does is that they'll allow the insurance companies to reset your profile, and so your secondary insurances may be more expensive. So generally, if you're going to go into traditional, it's best to do it when you first join Medicare and stick with it. Now, why is this so important? Is because the out-of-pocket expenses are much higher than managed care plans. You might pay less in premiums per month, but then you might find out that you have a $75 deductible for the doctor. They're not covering this medicine, not covering that medicine. There might be higher deductibles and stuff, and especially for infusibles, injectable medications. Because if you're on Medicare and you need an injection, basically what will happen is that those will basically be available often at no cost after your deductible is paid, because your secondary will pay the rest of it. So it's usually the best insurance to have if you have an in-office treatment. Again, not every prescription has that option, but if the option is that it can be delivered in a physician's office, generally you have very little to no out-of-pocket expenses on these name brand drugs. Now, remember, managed Medicare is basically private plans, and you basically give up your Medicare rights to a private company in order to eliminate the premiums. So again, out-of-pocket expenses are definitely higher. So copay cards. If you're basically on a government plan such as Medicare, Medicaid, Medicare, Medicaid, or managed Medicare, copay cards are generally not allowed. So that's a problem when you get a prescription from a pharmacy and they give you a copay of X number of dollars. Basically, you're not allowed to use copay cards. You are allowed to use them on commercial insurances if you're less than 65, or if you're over 65 and you're on your employer's insurance, then you can usually use them. So these are often used to reduce the cost of medications. Now, there is an exception to this called low income subsidy, and it can be available to reduce your copay costs, but you have to qualify and you go basically on cms.gov website, and they will have forms in there. You fill them out and you'll see if you're eligible. And if you are, then potentially you can get your co-pays on your prescription medications reduced. But this is only, certain folks will be able to apply for this. And again, everybody else in Medicare, pretty much no copay cards. Now, if you don't have insurance, that doesn't mean you can't get medications. Basically, the first thing you got to do is work with your doctor. Tell your doctor that your situation is X, Y, and Z, and generally they'll work with you. You'll find that mostly it's going to be doctors that own their own clinics or private practice can reduce prices, and they can also coordinate care, write your prescriptions. Unfortunately, most big systems require you to have health insurance, or they won't see you, or they'll see you at ridiculously high costs and are not negotiable. And also remember, there are several free and charitable clinics in Palm Beach County. Our medical society runs Project Access, and the arthritis, there's an arthritis clinic through Creaky Joints, and all kinds of clinics in the county. And so what you do is contact the medical society, and they'll give you assistance. And there are, probably some clinics you may qualify for, even if you're uninsured or unable to for insurance. Now, in terms of no insurance, generic medications, again, local pharmacy, discount pharmacy, and then use a coupon card or go through the online pharmacies. In terms of name brands, believe it or not, sometimes I have an easier time getting name brand medications for people who have no insurance, because if you are truly low income, the pharmaceutical companies all offer free drug. And you just have to fill out some forms. And basically, usually if you're in a free clinic, they'll help you do that. And what you do is you start by contacting the patient assistance information for your medication. And those are usually online. If it's a particular drug, you just write the drug name, and then you go to the website, and then you fill out the patient stuff. And you're going to find that there's usually assistance for that kind of stuff. But again, you'll have to get your doctor involved, have to write a prescription, and then you just have to fill out a couple forms. But I've not had difficulty getting people who have no insurance medication. Sometimes actually it's easier than sometimes people who have insurance. And again, if you're unsatisfied, you should consider changing your health insurance plan. If you're Medicare, there are different D plans. If you're on PPO, you might want to try a different kind of plan. And again, with traditional Medicare, there are literally hundreds of options for D plans. And if you have an employer-sponsored plan, talk to the plan administrator, because sometimes there are upgrades that you can purchase yourself to your insurance, or they may offer you a menu of different insurances. So let's say you're commercially insured. Okay, name brand. Okay, we basically generally expensive, mostly because the PBMs demand rebates, and basically prescriptions have to be approved, and there's a lot of paperwork. Trust me, on our end in the offices, it's a lot of work for us to get somebody's prescription through. And then what will happen is that then there's usually a high deductible. So then what you have to do is you have to apply for a patient's assistance copay card. And this is what you can do if you're on commercial insurance. And generally, these will reduce your cost to nothing, or maybe $25. And they're basically for anybody, any income level. But again, they don't apply for Medicare. If you need a generic, again, check the online prices, check the online pharmacies, and compare those to what the pharmacy says the insurance price is. And if so, then basically just pull up the coupon and ask them to fill it based on the coupon and not go through insurance. So one thing about commercial plans, you got to be aware of something called the accumulators. And there are accumulator programs right now that prevent the copay assistance cards from actually applying towards your deductible. So this is really an egregious thing. This should be made illegal. And there are several groups trying to work on this. But essentially what they do is they double dip. They take the money from the copay card, and then they don't give you credit for your deductible. So somewhere in the middle of your therapy, then you find out that your copay card doesn't work anymore, and you still have this high deductible because they never gave you credit for the deductible, even though you paid, towards it. So the expenses out of pocket go way up. And I have a couple patients who are caught in this, and it's essentially every 6 months they have to either change medications, go to a different program, or sometimes towards the end of the year they end up, not being able to fill their prescriptions. And this is just egregious, and it's going to cost the system a lot more money because people get sicker and they're going to need more health resources to pay for their flares. So again, multiple insurances. There might be some people that have that. Like, for example, you might be eligible for the VA and Medicare. We'll see which one covers the medication the best. You don't necessarily need to see one versus the other. So, remember that, if you're covered under different systems or potentially can go into another system, try to take advantage of that. Now, over the counter, interesting situation. Generally, over the counter medications are not that expensive, but they can be sometimes. And so there are several that can be available at prescription and over the counter. So, for example, the price for the prescription might be lower than the over the counter price. So you might be better off just asking the doctor for a prescription and then basically getting the prescription of the medication rather than getting and purchasing it over the counter. So what you need to do is you got to do your homework. You got to check your prices, and then you can figure out if it's an advantage to you or not. And then also, if you want a bigger discount, sometimes a discount card on the prescription might even give you a bigger savings overall. So this is an experiment I did the other day, and I checked out famotidine and the omeprazole, and I checked the price with a coupon card, which is GoodRx. I checked the over-the-counter price if you just purchase the medication without a prescription, and then I checked the insurance price. And what we find here in this instance with the famotidine, which is the generic for Pepcid, basically the coupon card price was better than what the insurance price was or the over-the-counter price. In other words, you paid more money to pay over-the-counter without a prescription than if you just went through a coupon card. But the biggest savings I got was omeprazole. My insurance only charges $2.55 for 90 pills, but it was going to cost $41 to get 84 pills if I bought the boxes off the shelf, and the coupon card was $15. So with the coupon card or the insurance, I would have saved a lot more money. So this is a multiple that's huge, between $2.55 to $41, just by getting a prescription rather than actually just buying the medicine without a prescription. So lastly, international pharmacies. They are legal and allowed in Florida, and basically you can purchase medications from Canadian pharmacies. This might be a good option for people who are getting name brands. I had a patient today who is on blood thinner, and a 90-day supply right now is about $1,600 to him with insurance, and the GoodRx price and the coupon prices are much better. And so essentially, if he goes out of the country, he can reduce his prices by more than half. So that could be an option to you. But again, you got to make sure the pharmacy is reputable. There are websites to check for that. I have that in the website, but this is also here. Just go to fda.gov, be safe RX, and they'll tell you whether or not the pharmacy is safe and legal. And then you can consider that as also another option. So as far as resources, the Prescription Drug Transparency Initiative is on the Palm Beach County Medical Society website. Basically, we are here to advocate for our patients and our community. And also, you can find us, you can call us, but a lot of the resources to basically save money is online. And we want you to basically be able to get your medications. We want you to be healthy. And the best way of doing that is to drive these drug costs down. And we're advocating very strongly at a federal level, at AMA level, local level, to try to get our local officials to listen so that we could get some control over these egregious policies of PBM so that we can get these prices down and so that we have more transparency rather than having a system where it's very difficult to know what things cost. So with that, we're going to open up for questions. So in chat, I don't have anything right now. So we'll let that go in for another second or so.
Thank you, Dr. Baca. That was really awesome.
You're welcome. I'm sure that you have this probably in your office all the time where you
Yeah, all the time, every day.
have to
So
juggle
I
some of
think
this stuff.
I think this is another reason why the society is such an incredible source of spreading good information. Like this, there's a lot of people that are uninsured. There's a lot of people that they don't know what to do. So what I wanted to ask you is, what do you think would be the best way, number one, to spread this talk from today, which has been incredibly excellent. Number two, to let people know that they're not alone, that there is options. Number three, we just entered enrollment season, and a lot of the people that are 65 and older don't understand that the options they may choose may not be the best for them. So this talk has been an incredible eye-opening experience for not only me, but it would be for anyone. So I ask, what would be the best way that you think we can spread, like reach out to individual physicians like myself? I have a very strong social media platform, other physicians, that we can spread this and make sure that people know where to go, when to go, and how to go there.
Well, I think that everything, politics is local. So, put the link to the Medical Society Drug Initiative on your Facebook and your Instagram pages. This is very important for patients. What we do with the Medicare enrollees is we actually have posted, and we actually have flyers in the waiting room, just reminding them that, these headhunters are coming after them to sign up their Medicare. And what they don't understand is that if you change from Medicare to a Medicare Advantage plan, the person signing you up, the insurance agent, gets $1,000 per head. And so that's why they're so aggressively hunting people down. But the reality is you're giving up a lot, for doing that. And I see that, on television, they're saying, well, we'll pay for your groceries or this or that. But what they don't tell you is that you're not going to be able to get any health care because they're going to have very limited panels and all kinds of other stuff. And again, we need our elected officials to rein this in, because, in Medicare, they only let you have a coupon card because they think it's an inducement, and to induce people to have money. But they don't think it's a problem that an insurance company offers you $500 a year to pay for your groceries and gives you cash, and they don't think that's a problem. So there's a lot of schizophrenia in the system. But the best thing you can do is, get the word out. These videos will be recorded, and they will be on the website, and they'll be available on YouTube. Yep. Go ahead. Another question?
So I don't know if you know that for the first time in history in the United States, this enrollment season, CMS is allowing a $250, like I can pay an insurance person $250 in cash to bring a patient to direct a patient to my office. This is the first time this has happened in history, but it's here. It's considered legal under this administration. I can send you the link. We are dealing with it every day. We haven't taken part of it. We don't think directing patients to a certain office, it's okay, but it is. And it's a big thing that a lot of the corporations are spreading during this enrollment season. So this is why what you're doing today is so incredible, because we're fighting a very big war.
Well, we are, and essentially what we're fighting is the corporate takeover of medicine. There are plenty of good studies now. If you look at the JAMA, there are studies that say that if a corporate practice owns the physician's office, the average cost to the patient is about 20–30% more than if the patient was seen by a private practitioner. Same thing with the pharmacies. They're talking about not knowing their patients because they're running too many people through. It's the same thing with the corporate stuff, locally owned. We need local pharmacies back. The local pharmacy used to be the center of the community. That's where the lunch counter was. That's where, some of the most significant changes in our last century occurred over lunch counters. and the local pharmacy, is where you used to have the political debate, and that's all gone now. So we're trading that for profits and losing our humanity. So I totally
And
agree.
don't forget, if we ignore the basics, we will always fail. It's always a cycle. We go from a little person to an older person and back to a little person. Life is always a cycle. We're back to understanding that a little place where you can have a one-to-one connection is the only way to go.
Right. Exactly. So, all right, we have time for one more question, maybe. Okay, so I'm going to thank Stevi Jenkins for being on. It was very informative. Essentially, this will be recorded, this will be online, and anybody can look at this as a reference, but I think that most people can probably save some money if they look at this, because there are lots of little tricks, but you first have to have knowledge in order to know this. And so start with the coupon cards and start with the online pharmacies, check your prices, just like you would if you're buying a car or something else. I mean, it's kind of silly that you have to do that to buy a drug. It's like buying a used car, but that's the system we live in right now. So if you can do that, then you can work around it. And Florida has, rules protection. So the pharmacist technically, can help you, whereas in the past, some of the big corporations put gags on them and didn't allow them to tell patients about how they could save money. So, they're professionals just like physicians are, and they're bound by ethics. And, so we try to, to remember our humanity. Kelly.
Yep, there's a question in the chat, Dr. Baca. Someone wants to
Okay.
know, what is ATAP?
Okay, so ATAP is basically an association that we actually now are endorsing, and this Alliance for Transparency and Affordable Prescriptions. So you can learn more about that if you listen to the first video. But essentially, they've been sounding the alarm bell for many years about this rebating system and all this craziness that's going on. And there have been some minor victories, like the FTC is finally starting to investigate whether or not kickback, rebates or kickbacks. But it's starting to cost the government a lot of money, and we're all paying for it. And so, hopefully someday, we'll see some resolution. Dr. Rodriguez.
Dr. Baca, this might be a big question, but this is so good and so awesome. And there's so many people lost that they don't know. It's not only about cheaper, but it's also about access.
Right.
How do I access something? I don't have insurance. What if we also put this in caption with Spanish and Creole?
We could try doing that. I think that's
I mean, I know
doable.
it's a big deal, but maybe we can get a team together so that as you guys are talking, there's a caption that's translated into Spanish. And this is really good, Dr. Baca. Thank you so much.
Yeah. Okay.
And again, it's not about being there, it's about access. There's a lot of people that do not know where to go.
Suggestion. Okay, so let's see if we can work on that. Okay, so our leadership is here, so let's work on that. We can probably find a translator, and maybe we can see if we can put in a caption underneath. Okay, good night, everybody, and be safe.
Good night. Thank you.
Thank you.
Thank you for attending, everyone.
Thank you, Mindy. Thank you, Kelly.